So here I am going to teach you about a topic about strokes, uh, how to localize stroke, and how to recognize which artery is involved in what type of stroke. For recognizing the pattern of stroke, first we should know the location of the nerves, because they will help you diagnose where the site of lesion is. What you should know, as you can see in first here, 4 4 4 4. First 4 are present above the pons, and then 4 are present that exits the pons, and then there are 4 which exit the medulla, and 4 of them are medial, and the medial one are those that can be divided by 4. Okay, this will help you recognize what pattern and where is the lesion. So we will now move on to the part where we have to recognize the lesion. Okay, now we will start from here. To start with, first we will talk about the anterior cerebral and the middle cerebral and the localisation artery which are present there. The very simple trick to recognize them, that anterior cerebral artery involves the upper limbs, while the middle cerebral artery, I just I would say I just told it in the wrong way. Anterior cerebral artery involves the lower limb, while the middle cerebral artery involves the upper limb as well as face. This is the main differentiating feature. If a patient comes with weakness in leg or urinary problems, it is the lower limb that is involved, so the artery would be anterior cerebral artery. And if the person comes with weakness or with a weakness in the upper limb or in facial involvement, then it is going to the middle cerebral artery. In middle cerebral artery, the face and the face which is involved as well as the limb that is involved is on the contralateral side. There is nothing spilateral here. That will help you to separate it from the midbrain part, where facial involved in the oculomotor nerve is involved spilatory, while body is paralyzed or weakened contralaterally. We will come to it later. So you will be able to differentiate anterior cerebral artery and the middle cerebral artery. But middle cerebral artery, there's two areas. There's area Wernicke's area, which is present in the superior temporal gyrus area. It is also important. They can also come as an BCQ. While Broca's area is present in the inferior frontal gyrus. So these both parts are also affected by the middle cerebral artery. You should know that. It should be remembered by you. So if Wernicke's area is involved, what would it tell you? It will tell the middle cerebral artery. And Wernicke's area, how will you diagnose? A person is not able to recognize what you are saying. Or Broca's area is involved, in which a person is unable to speak fluently. There's a word slur. Then it means that Broca's area is involved. And where would it refer? It would refer you toward the middle cerebral artery. And you also know that if temporal lobe is involved, we have superior quadrant visual field defect, superior quadrantopia. And I remember in parietal we have the inferior one, so you should note that. There is also Gertzmann syndrome. We will talk about later. I will not talk about at all. You will do it on yourself, because now we are just trying to localize the lie. Okay, then come to the localisation artery. Important to know that it usually happen with the chronic hypertension, that is called lipohyalurosis. So it supplies the capsule. Capsule has anterior limb and the posterior limb. Posterior limb is purely motor, anterior limb is sensory. So usually when localisation artery is involved, or when the internal capsule stroke is there, they will give you a pure motor stroke. In anterior limb, anterior cerebral artery and middle cerebral artery, they were both sensory as well as motor effect. If only motor factors are there, then it means that it is purely motor. And if it's contralateral involved, then you can think about the localisation artery. And if there is history of hypertension, it strongly suggests that localisation artery is involved. There is no effect like neglect, aphasia, and visual field loss that we have above in the middle cerebral artery or anterior cerebral artery. So these are three that you can diagnose them from here. When we move on, so as we remember, I have told you about the nerves, which nerves are where. So when we talk about the posterior cerebral artery, okay, posterior cerebral artery, we all know that they supply the occipital lobe, and it causes the visual loss with macular sparring, and this macular sparring can separate it from the middle cerebral artery, in which there is no macular sparring. Okay, that's differentiate you from there. But further on, moving on, if we talk further about the Okay, so we were talking about posterior cerebral artery. Posterior cerebral artery basically supply your midbrain. So what nerve arise from midbrain? These are the nerve that arise above the pons, which were 1 to 4. So mainly the third nerve, oculomotor nerve, is bilaterally, as in Weber syndrome, and the contralateral hemiplegia is involved there. Other thing that can happen in posterior cerebral artery when the occipital lobe is involved, we have told about homonymous hemianopia with macular sparing. And when the VN is effective, alexia with agraphia would be there. You will not be able to read something, you will not be able to read something, but you can write it. But no, there's no agraphia. And if a non-dominant is involved, you won't be able to recognize, as your vision is problematic, you will not be able to recognize someone who you know already. Okay, and further, if we talk about, now we move ahead. Okay, for moving ahead, first I will show you the blood supply so that you know which blood supply is involved. This diagram is going to be helpful in this scenario now. Okay, what you know from here, when you see here, when you know the circle of Willis, how it is formed, first there are vertebral arteries and there is the anterior spinal artery here. So this pass, to what part this is related? It is related to the medulla part. Medulla is below, so this is the basic part that is below. It is involved to that part, which involve 9, 10, 11, 12. Okay, then there comes the posterior cerebral artery. Posterior cerebral artery, then there come a basilar artery. So two vertebrae form the base. They form the basilar artery, which give the pontine artery. And then there is anterior-inferior cerebral artery, and then there is the posterior cerebral, and then there is the posterior cerebral artery ahead. You can see it from here. Posterior inferior cerebral artery. Maybe I have told something mistakenly, but you can recheck it from here. Posterior inferior cerebral artery, anterior spinal artery, vertebral artery, form the basilar artery, give the pontine artery, and then the superior cerebral artery that I just mistold you, and then there's the posterior cerebral artery. Okay, so posterior inferior cerebral artery will be supplying these are supplying the medulla part, and this pontine artery and basilar artery would be supplying the pontine part, and posterior cerebral artery supplying the midbrain. So we are going ahead from medulla to pons to midbrain. So nerve are affected in the same order. Let's move back. Okay, so we have the basilar artery. So what part basilar artery will affect? As we have read behind, basilar artery are that form the base. In the base there is medulla, and what nerve medulla have, you should know them. But the other thing also, I'm sorry, just again told you a bad thing. As we have told, we have the vertebral artery down, and they form the base basilar artery. So basilar artery supplies the pons. So pons is also related to the reticular system, which is responsible for our activation. So if pons are affected, basilar artery is affected, pons will be affected, pons will be affected, reticular system is affected, and reticular system is important for our consciousness and our activeness. So we may get into coma. And there is another syndrome which is locked-in syndrome, which is also due to basilar artery due to the pontine damage. And locked-in syndrome, you are not able to move your four limbs, you are not able to even move your eyes horizontally, but you can move in vertically. So this will help you diagnose the pontine syndrome to the basilar artery, which base formed from the vertebral artery. But later on, if we move toward the anterior inferior cerebral artery, which formed just above the vertebral artery, it also supplies pons. It also supplies the pons, and what were there from the pons? It was 4 to 8 nerves. So one nerve that is very important for diagnosis of anterior inferior cerebral artery as a pontine problem is facial nerve nuclei. If facial nerve nuclei is involved, you will definitely think about pons, and when you will think about the pons, you will think about the anterior inferior cerebral artery, which also supplies the pons, because when we talk about the basilar artery, it has pons here. So when it has the pons there, and the artery which is just below the basilar artery, anterior inferior cerebral artery, it also supports the pons and so supports the facial nerve nuclei. Okay, so when the facial nerve nuclei is involved, facial palsy is there, you will definitely think about anterior inferior cerebral artery, and anterior cerebral artery is involved with the lateral pontine syndrome. Okay, we will also talk about other one which is ahead, but it is lateral pontine syndrome. Okay, other thing that will be affected there is 8, because it is at the conjunction. It will also affect the nerves that are present below, which are in the medullary area. Okay, so it will affect the vestibular nuclei, spinothalamic and sympathetic, and the other one. So the point here is the diagnostic point is facial nerve, and the other thing that will help you is basically the spinothalamic artery, the spinothalamic tract, and trigeminal. If the spinothalamic tract is affected, what will happen? The thing that will help you here is basically all the things are spiratory facial nerve, spiratory horner syndrome, spiratory ataxia, spiratory sensorineural deafness, except one thing, which is pain and temperature, which is contralateral. So now we have talked about the main things. Anterior cerebral artery, lower limb, middle cerebral artery, upper limb, lenticostenoid artery, purely sensory, posterior cerebral artery, macular sparring, basilar artery, locked-in syndrome, anteroinferior cerebral artery, facial nerve. Let's move ahead. There are two left now, posterior inferior cerebral artery and the anterior spinal artery. So as we talked, posterior inferior cerebral artery is where we know posterior inferior cerebral artery is present quite below, so it will be supplying medulla. And what nerve are basically related to medulla? They are basically 9, 10, 11, 12. So if 10 nerve is involved, you will definitely think about posterior inferior cerebral artery or lateral medullary syndrome, as medulla is there. Medulla has those nerves. So when the lateral medullary syndrome is there, there may be dysphagia, there may be some other thing like hoarseness, and these are very characteristic of it now. And the other things are same, like lateral pontine syndrome. So differentiating between them, it involves 10, the previous one involves the 7. So if nucleus ambiguous is involved, dysphagia, hoarseness is there, it will definitely point toward posterior inferior cerebral artery, which will point toward medulla, lateral medullary syndrome, Wallenberg syndrome. Other things are same: pain and temperature, contralaterally, spinator phase, spinator horner, spinator ataxia, and dysmetria. Now we'll talk about the anterior spinal artery. It was the artery when we saw the vertebral artery, there was the artery which is coming between them, center. It was anterior spinal artery. Now, this artery, this is the diagnostic about this artery is this also involves the medullary part now, but it is the medial, so it come in the medial part. So what if we have in the most medial part of our body is our tongue. It is present in the medial. So if tongue is involved, and usually tongue is, you know that tongue supports you, tongue is the one that go toward the lion, it go toward the spinator side, that we have also talked about in the hypoglossal nerve, it go toward the side of the lion. So there it do the same, it go toward the side of the lion. So if spinator hypoglossal function is involved and the contralateral pulses, and the track is different here, there is contralateral pulses is there, then you will definitely think about the anterior spinal artery or vertebral artery. So hypoglossal nerve, now we will summarize it now. Hypoglossal nerve will be involved, it will go toward the anterior spinal artery. If vagus nerve is involved, posterior inferior cerebral artery and lateral medullary syndrome. If anterior inferior cerebral artery is involved, it will go toward the lateral pontine syndrome, and the facial nerve is there. Basilar artery, locked-in syndrome or activity. Posterior cerebral artery, macular sparring. Lenticostenoid artery, purely motor, purely sensory. Middle cerebral artery, upper limb, and anterior cerebral artery, lower limb.